I'm Caroline Green.
And I'm Nick Kendrew.
We're both part of the Redwell team.
Come with us to reignite your passion for primary care.
Welcome to the Back to School Feeling Primary Care Pod from Redwell.
The Primary Care Pod from Redwell.
And it's a warm welcome back to Caroline, and also thanks to Ali, who was with us last month. And it's another bumper month. We've had 5 pearls released in the last month, and so we've got lots of content to share with you. So it's going to be another 2 episodes this month. So grab your preferred drink of choice or your trainers, clutch your pearls, and let's start with the headlines. Here's what's coming up this week. Wilson's disease, is that something to do with copper? Well, yes it is. And you may not have heard of it or come across it since university, but every now and again it's good to take topics like this down from the shelf and give them a little dust. And then if we do come across them, the neurons fire and the light bulb goes on.
To celebrate a new cohort of trainees joining Team GP, we wanted to share one of our most coveted Guidelines and Evidence Made Simple, or GEMS. It contains everything you need to know about how to approach all types of anaemia in primary care.
A message on the triage list. Going hiking in Slovenia in September. Any vaccinations needed? What would be your immediate answer? Did you know that tick-borne encephalitis vaccination may be recommended in this situation? And here's what's coming up next week.
On the 15th of April 2024, big changes were announced in the process for death certification, and these came into play across all of England and Wales on the 9th of September 2024. So, we ask the question, the National Medical Examiner System? England, Wales, are you ready?
To many of us, the sheer choice of HRT regimes can feel baffling, but a simple message is that for all women who still have a uterus, unopposed estrogen can increase the risk of endometrial cancer, so it must be balanced with an adequate dose of progestogen. But what is an adequate dose? So back to the beginning and our first pearl, and Wilson's disease. Now, it's funny how things work out, because about a month ago, a hospital consultant in London wrote to me to ask if I could arrange a local blood test for a patient with a movement disorder. Now, amongst other things, they asked me to check their serum ceruloplasmin. Easy for you to say. Now, I've never been asked to check that before, and I'm pretty sure I've not requested it myself before, so I had to look up what it was. And then here we are, going to be talking about it a bit more in a moment. Now, this one took me 6 minutes and 17 seconds to read, so a nice quick espresso shot of learning. Caroline, what did this one mean for you?
Yeah, this was one that was definitely a trip back to those MCQ exams at university. Something around eyes and livers ringing a bell. And as you said, Nick, we deliberately pick topics sometimes that you just won't learn about anywhere else. So in that rare situation when they do walk through the door in primary care, those neural circuits fire, or at least we know we can look it up on Redwell Knowledge anyway.
Exactly. I normally kind of think, I know I should know about this, but I know where to find it. So that's all good. Now, as always, the written pearl has all the detailed references, but the inspiration for this article was a New England Journal of Medicine review article from 2023. So for those needing a reminder, Wilson's disease is a genetic condition which causes intracellular accumulation of copper, resulting in liver disease, neurological symptoms, and psychiatric symptoms. It's very unlikely we'll ever make a diagnosis of Wilson's disease ourselves. However, from a primary care perspective, we may suspect it and refer or have a patient on our list with known Wilson's disease. So, Caroline, how common is it?
It's not very common. So it affects about 30 people in every million.
So hopefully that's reassuring for those of us that worry that we've missed something, me being one of those. But what causes Wilson's disease? Can you kind of give us the science bit?
Well, yes, I certainly can, or at least a primary care ready view of the science. So listeners, if you are a Wilson's disease expert, this is not for you, but this is for the rest of us. So Wilson's disease is an autosomal recessive condition, and it's due to several different possible mutations in the gene for the ATP7B on chromosome 13. Basically, this gene provides instructions to make a copper-transporting ATPase protein. And if this is absent or malfunctional, is that a word? I'm not sure. I like it. Malfunctional. Basically, it results in copper accumulation inside of cells. Now, it can present at any age, but it's more likely to present for the first time before the age of 50.
And why is Wilson's disease important? What can it do?
Well, it's a multi-system disorder. It can affect actually pretty much any part of the body. And in the written Pearl, there's a really useful table that's based on that great NEJM article from 2023, but also a Cochrane database systematic review from 2017. And we'll take a run through now, starting with the liver, which is often affected first. So copper accumulation causes liver cell injury. And so it might present to us with abnormal LFTs, it might present with hepatitis or cirrhosis, but it can also be silent in the early stages. And as the disease progresses, what might be the first calling card are neurological or psychiatric symptoms.
Now, when the neurological system is affected, Wilson's often affects basal ganglia and so causes movement problems. So we should look out for dysarthria. Patients may also have drooling or difficulty swallowing, dystonia or athetosis.
Remind me, what's the difference between those, Nick?
Well, dystonia is the name for uncontrolled and sometimes painful muscle spasms, a movement disorder causing the muscles to contract, whereas athetosis is another type of movement disorder that affects the hands and feet, arms and legs, and can sometimes affect the neck and tongue. Movements are often described as involuntary, slow, and writhing. So if there is either of those two, or if they are in combination with others, then we should consider the possibility of Wilson's. Decreased movement, similar to Parkinson's rigidity, may also be a feature. There may be poor coordination or loss of fine motor control. This may present as clumsiness, loss of coordination when playing sports, or decreased school performance. And there may be a tremor. This may be a fine tremor with or without head involvement, or there may be wing beating tremor, which is often described as typical or characteristic of Wilson's disease. And I'll put a link to the NEJM YouTube video of this in the show notes. Interestingly, these movement disorders usually occur without any impact being seen on cognition.
That is interesting. There may, however, be psychiatric symptoms which could include depression, bipolar disorder, psychosis, anxiety, phobias, aggression or antisocial behaviour. So quite a wide range of things there. And I guess this falls into that category that we sometimes talk about at Red Whale of something plus, so movement disorder plus psychiatric symptoms. If you start to see an accumulation of these things together, there's something unusual going on. And my guess is this would be very much the time for phoning a friendly neurologist and getting some advice. The eyes can also be affected, and there might be those rings that some of us might remember from finals, so Kaiser-Fleischer rings, but it's worth noting they're only present in about 50% of cases and less time if the patient's younger, so the absence of them shouldn't put us off the diagnosis. Interestingly, there's also this phenomenon called sunflower cataracts that we might see, and these are central lens opacities that can be multicoloured and radiating, I guess again because the copper gets deposited within the cataract. So, having considered the more common systems affected by this rare disorder, we also need to bear in mind that it can also affect bones, muscles, the endocrine system, kidneys, reproductive tract, cardiac and haematological. There are more details in the table, but for most of us, we'll only get this far at looking at those if we've actually got to the point that one of our patients has a diagnosis and we're trying to learn more about it.
Yeah, exactly. But what about actually testing for it?
Well, spoiler alert, we don't measure free serum copper.
Why is that?
Well, as we've said, when we think about Wilson's disease, what we're thinking about is high copper, but it's intracellular levels that are high. bound serum copper is low. So the person has too much copper inside their cells, but potentially less circulating in their blood. And I'm sure that we all know that when the ATP7B functions normally, copper from the portal circulation is processed inside the hepatocyte by the ATP7B, and it's then packaged up as hollow ceruloplasmin, which then circulates in the blood.
I totally knew that, as I'm sure you could tell.
Yeah, absolutely. Me too. I didn't just read it for this podcast. In Wilson's disease, because the function of that ATP is decreased or absent, the copper accumulates inside hepatocytes. So extracellular hollow ceruloplasmin levels are reduced. So because of that, we don't measure serum copper, we measure serum ceruloplasmin, the bound form. And that's usually low in Wilson's disease, though it can be normal. A level of less than 5 milligrams per deciliter is strongly suggestive of Wilson's disease. And if this had crossed our mind, if we were having a particularly clever day in primary care, if we're doing tests for this, we should also do a full liver panel at the same time, because that might give us more information. The article also mentioned doing a basal 24-hour urinary copper excretion, but realistically, I think we'd only probably be doing that if we were requested to by secondary care. What do you think, Nick?
Yeah, certainly. That's exactly what I'd be doing. I'd wait for them to tell me to do that.
Me too.
Yes. Now, if we suspect Wilson's disease, then
even
we
better
should
do
refer.
It themselves.
Well, yes, absolutely. That's a can of worms, but yes.
Yes. Anyway.
So if we suspect Wilson's disease, then we should refer. And we don't need to do anything else in primary care, just refer, which is a wonderful thing to be able to say. We don't get to say that very often. The diagnosis will be confirmed in secondary care with a liver biopsy and or genetic testing. Now, secondary care may also arrange imaging of other systems. For example, in those with neurological symptoms, an MRI of the brain often shows basal ganglia abnormalities. If Wilson's disease is confirmed, then all first-degree relatives should be offered screening. Now, screening may involve clinical or biochemical assessment, genetic screening, or both, and we'd expect secondary care to lead on this. Without treatment, Wilson's disease is progressive and fatal. With treatment, life expectancy is similar to the general population, so it's so important to get that diagnosis. Copper-rich foods should be avoided and dietitian input may be offered, but Wilson's disease can't be treated by diet alone. So what are the medical treatments, Caroline?
Well, the mainstay of treatment is copper chelation, and the main drugs that secondary care would tend to prescribe would be either penicillamine or trientine. And what these do is result in urinary excretion of copper. Management will also include, obviously, screening and monitoring for end organ damage, for things such as cirrhosis, and if it's present, treating for its complications. And in some situations, patients with Wilson's may end up needing to be considered for liver transplant. The bottom line is that as a rare multi-system disease, management of this is going to be very much led by secondary care with a multi-professional team and a multi-professional approach. But of course, we'll be seeing these patients with all of the other things and be part of their care. So just useful for us to be aware.
Now, if you are a Red Whale Knowledge member, then you can have a look at the article Liver Disease and Cirrhosis for more information on the management of cirrhosis. And if you're not yet a Red Whale Knowledge member, then stay tuned until the end of the episode for details on how to get your 10% discount when you sign up. Or if you are a GP ST1, 2 or 3, then make sure you come back next week to find out how you can get free access to Red Whale Knowledge support for your learning and exam preparation. So, here are your learning points for Wilson's disease. It's a rare autosomal recessive condition causing intracellular copper accumulation. Think about it when there is liver disease, movement disorder, and psychiatric symptoms.
If you do measure copper, measure the bound form, serum ceruloplasmin, and remember it will be low because all the copper is in the cells. If you suspect it, refer, and remember the mainstay of treatment is lifelong copper chelation and support from a multidisciplinary team. It's worth treating because appropriate treatment and compliance results in a life expectancy similar to the general population.
So that's the first one done. How are you doing, Caroline? How was your holiday?
Yeah, good. I've very much got that back to school feeling. My daughter's gone back to school and I can get back into routine. Our holiday was great. It feels a long time ago now. We braved the rain on Arran and the Cairngorms, and funnily enough, Nick did loads of fun, adventurous, fairly risky activities, all survived unscathed, and then came home and my daughter broke her foot skipping in the garden and my husband tore his calf playing laser tag. So we had a bit of a sort of hectic end to the holiday, but all is well now. How are you?
Oh, I can't compete with that. That's a dramatic end to the holiday.
Sorry.
I'm okay, thank you. I'm currently locked in the house though because the front door lock is broken. But it's all right. I can get out if I need to. Yes, I'm just waiting for a locksmith to rescue me.
Oh dear, that also sounds quite dramatic. That's how we roll at Red Whale. We keep you locked in so you do all your work. You see. Exactly.
Help. So, shall we move on? We move on to our if you're listening to this, send help, please. No, it's fine. So, if we move on to our second
or at least
pearl now. Yes, exactly. So our second pearl. Now, this is the one that we asked you to share far and wide. If you are a new member of the Red Whale Pod because somebody shared the pearl with you, or if you are one of the new cohort of trainees joining Team GP, then a very warm welcome to you. And if that's you, then please send us a text message telling us who you are and where you are and even what you're doing. If you just look at the episode blurb in your preferred podcasting platform and press where it says send us a text message. Now, if your phone plan includes text messages, then a text to us is included in the plan and it won't cost you anything extra. Otherwise, it's just like sending any other text message and is charged at your standard network rate. There are lots of people listening all over the world. So I also need to say that if you are abroad and you text us, and when I say abroad, I mean away from the country that your phone is registered in, then it's like sending any other international text message. There we are. So, Pearl 2. Now, this was our anemia gems. Now, this one took me 18 minutes and 16 seconds to read, which is our longest pearl of the month. So I reckon that deserves some hygge for all of our Danish listeners. So a heartwarming hug of hot chocolate and an ice spice bun. And you know the one that I mean. So what did this one mean for you, Caroline?
Oh, this one's a bit of a lifesaver, isn't it? So we know that lots of people use this GEMS and our other GEMS week in, week out to help just to give them the scaffolding to work through blood results or long-term condition management, either, you know, in that early morning slot or later in the evening when you're trying to get through everything. And the anemia GEMS has recently been updated to take account of the new guidance on FIT and also the new NICE guidance on B12, ready for our blood test course that we're going to launch later this autumn. But yeah, a lifesaver. Yes,
and I'm sure we all know the scenario. It's late, you have 30 blood results still to process, and everybody seems to be anemic. Now, this pearl is going to become your new best friend for making decisions about anemic patients, especially when decision fatigue has set in. This one is a GEMS, or Guidelines and Evidence Made Simple, and there are actually 5 self-contained pages, each dealing with a different aspect of anemia.
Now, GEMS are absolutely packed with information and flowcharts that pull information together from a wide range of references into a single place so you can see them all at one time in clinical practice or if you're revising for exams. But Nick and I have noticed they don't always make the most inspiring content in the podcast if we just go through them from beginning to end. So what we've decided to do is pull out the key learning point, but we won't be covering everything that's in the GEMS. And we would really encourage you to go and look at this on Red Whale Knowledge. So the learning points centre around what kind of anemia is this? What's the underlying cause? And what do I need to do?
And the first question is, could this person be very sick? So do they have a very low hemoglobin or pancytopenia, or are they very symptomatic? If so, refer or admit now, depending on severity. If they're not very sick, then we can work out what kind of anemia this is by looking at the MCV. Is it microcytic, normocytic, or macrocytic anemia? If anyone is having a mental block, then this is determined by whether the red cells are small, normal sized, or large. The chart then navigates you to page 2 and 3, which cover microcytic anemia, page 4 for normocytic anemia, and page 5 for macrocytic anemia. Simples.
And then the next important learning point is to remember that anaemia is a symptom, not a diagnosis. So having identified that this person isn't very sick, but that they have anemia, the next question we need to be thinking about is what's the cause? Why were the bloods taken in the first place? What were the symptoms? We might need to review the notes, particularly if we're reviewing results we didn't request ourselves. And we might even need to review the patients. So going back to the red flags, just some tips here. The presence of anemia can warrant testing and referral for cancer. And here's a reminder of some of the situations that are covered by the NICE NG12 guideline, including the recent updates for FIT. So first, all adults with an iron deficiency anemia and adults aged 60 years and over with any anemia should be offered FIT testing and referred on the suspected colorectal cancer pathway if the FIT test comes back positive. So that's the first one. Think about colorectal cancer. The next one, all adults aged 55 or older who have upper abdominal pain and a low haemoglobin should be referred for an OGD because of the potential risk of an upper GI cancer. And female patients aged 55 or older with anemia and visible hematuria should be referred for a direct gynae ultrasound scan. And of course, remembering this stuff is really difficult. That's why we have the GEMS. And lots of us may also have things embedded into our primary care system, things like See the Signs that will help to pick these combinations of symptoms and to help just flag it at the end of a busy day.
Yeah, and all those things are there to help us with decision fatigue, aren't they? So if we've ruled out red flags, then page 2 takes us through how to interpret iron studies to decide between iron deficiency anemia, simplistically if ferritin is low, or anemia of chronic disease, which is also sometimes known as functional iron deficiency, if the ferritin is normal or raised. Now, there is a list of differential diagnoses to consider for each type to help plan further history taking, so targeted history, and also investigations. It also reminds us to check a drug history, so the usual culprits such as NSAIDs, SSRIs, antiplatelets and anticoagulants, particularly if there's no PPI gastroprotection.
Now, page 3 is interesting because it starts to talk about the management of iron deficiency anemia, assuming that we now know the cause. And actually, that's changed in recent years. Lots of us will remember a time when we used to prescribe iron tablets 3 times a day and then often going on home visits and finding vast stashes of unused boxes because people just couldn't tolerate taking them. And there's great news for patients. If we choose oral iron now as part of the treatment, it only needs to be taken once a day. And the advice we should give when prescribing oral iron is that it should be taken on an empty stomach on its own, so not at the same time as other medications, and not with a cup of tea, because interestingly, the tea itself, not the milk, can reduce absorption of the iron by up to 90%. So take it with a glass of water. Some people still find this difficult to tolerate, and if that's the case, it can be reduced to alternate days. And if despite all of those things, people still can't tolerate oral iron, or they have an underlying GI condition that impairs absorption, or they're on dialysis, then we might need to refer them for parenteral iron. And there's more information on that on page 3 of the GEMS.
Now, page 4 goes through a diagnostic approach to normocytic anemia. In this scenario, we need to check reticulocytes, which are immature red blood cells and tend to be raised if there is acute bleeding. Hopefully we spotted that before we've referred the patient, or if there is hemolysis or if the person has been at high altitude. We would also do iron, B12 and folate. And this is because a normocytic anemia could be a mixed micro and macrocytic picture. It may also be anemia of chronic disease, which can occur in many long-term conditions, including CKD, heart failure, liver disease, inflammatory arthritis, and acute and chronic inflammation and infections.
I don't know about you, Nick, but I almost find that one the hardest one to sort out, actually.
Yeah, definitely.
Yeah, and some days there's loads of them. But finally, yes. Page 5 looks at macrocytic anemia, and it starts to unpick B12 and folate deficiency. Now, this is complicated, and NICE produced new guidance on this just a few months ago, which we're actually covering this year on the GP update course and also the blood test course. Because, shall we say, NICE have made things a touch more complicated. Now, This GEMS that we shared with you covers a big picture approach, but if you have Redwell Knowledge Access, there is a whole separate GEMS on B12 deficiency and how to approach this. And we hope that we'll see some of you either at the face-to-face or digital GP update events where we can hopefully demystify this further. So here are some key learning points.
Are there any red flags for either a haematological emergency or cancer? If so, refer appropriately.
Anaemia is a symptom, so we always need to look for a course. Use the symptoms and haematinics to help you.
No one needs oral iron 3 times a day.
And use the GEMS to help when you're interpreting tricky blood results. For Redwell Knowledge members, there are 108 GEMS, including 16 on managing clinical results, to help when that decision fatigue kicks in.
So, Caroline, have you got the Redwell calendar there?
Oh, it's a busy month, September, for us. So we are, as we speak today, filming the new bites for the new season of GP Update. So we've got stroke, we've got heart failure with preserved ejection fraction, meningococcal disease, B12 deficiency, perinatal mental health, problematic bleeding on HRT. So all sorts of really important, useful general practice topics there. And that will be ready to consume in our live digital courses in October, or you can also get together with colleagues on our face-to-face dates in London and Manchester over October and November. A really nice chance to just be in the room with other GP and primary care colleagues from around the country.
Okay, so now it's time for our third pearl of the month, and this is tick-borne encephalitis, when to vaccinate. Now, this one took me 5 minutes and 34 seconds to read, so a nice quick one. Caroline, what did it mean for you?
Well, this was the one that made me think that I would have looked at Slovenia on the triage list and thought, probably nothing needed here. It's Europe. And I could well have been wrong.
Yes, and I think I would have been in the same boat as well. So tick-borne encephalitis is a viral illness usually transmitted through the bite of an infected Ixodes tick. Now, I think I've said that correct, but if you know differently, then please let us know. It's a flavivirus related to strains that can cause yellow fever, dengue fever, and Japanese encephalitis. There are now 5 subtypes: European, which is found in Central, Eastern and Northern Europe; Siberian, found in the Urals, Siberia, Far Eastern Russia and some areas in Northeast Europe; Far Eastern, found in Far East Russia, China and Japan; Baikalian, found in East Siberia; and Himalayan, found in the Qinghai Tibet Plateau. And the one that we're most likely to be concerned with is the European subtype, which is associated with milder disease. Since 2019, there have been small numbers of confirmed cases of tick-borne encephalitis in the UK, with evidence that the virus is spreading in geographical distribution. The virus is endemic in rural and forested areas of Europe and Asia. The risk of infection in the UK remains very low, but it's rising. The information for this pearl comes from the Travel Health Pro website and the latest guidance from the UK HSA Green Book Chapter 31 and the European Centre for Disease Control, all accessed in May 2024. So how does tick-borne encephalitis affect people, Caroline?
So interestingly, 2/3 of infections are asymptomatic, and the incubation period is between 2 and 28 days, though on average it's about 7 days. If people do get symptoms, then the illness comes in 2 phases. So there's an initial sort of non-specific viremic phase that lasts about 5 days. So typically with fatigue, muscle aches, temperature and headache. And then often an asymptomatic interval that can go from anything from 1 to 33 days, again with an average of 7 days. In about 20 to 30% of those people with the European subtype, they then go on to develop a second symptomatic phase. And this is the bit that's worrying, because this is the bit that can lead to severe neurological problems in up to 10% of those who get it, with an overall mortality of 0.5 to 2%. So the second stage usually starts with a sudden rise in temperature, and then the following features may develop. So children and adults can develop the clinical features of meningitis, and adults in addition could also get an encephalitis or myelitis picture occurring in about 10% of cases. For those who develop all of those things, so a meningoencephalomyelitis, 10-year follow-up shows that 80% will have long-term issues. But fortunately for us in the UK, the European subtype has the lowest rate of developing this second phase of disease, compared with the Far Eastern subtype that has the highest rate. Mortality is about 1% for the European form, but worryingly as much as 5 to 20% for the Far Eastern subtype. Now, if we suspect a case, testing for infection is done at the UKHSA laboratory at Porton Down, and we would access that by speaking to an on-call clinician at the UKHSA for advice prior to testing. That's what the official articles say. I suspect for most of us in primary care, if this did cross our mind, we'd probably be picking up the phone to the infectious disease team. And obviously, if the person was sick, particularly with those features of meningitis or encephalitis, we'd just be admitting them because we'd need a sort of wider workup than that. What do you think, Nick?
Yeah, I think absolutely. We'd be identifying a sick patient, wouldn't we, with that kind of history? And I think we'd be admitting them to hospital, wouldn't we?
We should remember, if this does cross our mind, tick-borne encephalitis is a notifiable disease and should be reported to the UKHSA, though obviously if it was diagnosed as part of a hospital workup, they would probably do that. So, Nick, should we have a think about risk factors?
Yes. So it's actually quite difficult to quantify risk because the reporting of tick-borne encephalitis across Europe is variable. But in simple terms, anybody who's planning to go walking, hiking, camping or working in endemic areas is at risk. Risks are highest in spring, summer and autumn, so peak walking months. Publicity about UK cases combined with the popularity of walking holidays may prompt an increase in patients seeking advice. Now, if we want to be tick aware, then we need to know about bite avoidance and tick removal. So bite avoidance, just as we do for patients going to malarial areas, we should give advice about bite avoidance. So dawn to dusk protection, long sleeves and long trousers. Also avoid heavily infested areas of forest. Now, I'm not sure how we work that out. If there's an easy way to do this and you know that, then please let us know. And we should also be advising the adequate use of insect repellent.
After walking and hiking, people should be encouraged to check their bodies for ticks and remove ticks using either fine-tooth tweezers or a tick remover. Now, again, if you've got Redwell Knowledge Access, you'll find more information about how to remove ticks in the Lyme disease article that you'll find there. So, Nick, what is the guidance then about vaccination?
So vaccination for travel or work within the UK is not currently recommended. The Green Book recommends the vaccine for individuals who hike, camp, hunt or undertake field work in spring or summer in endemic areas and those living in or moving into endemic areas, particularly those who work in forestry, farming and the military. The interactive map at Travel Health Pro will help identify areas of risk, and I'm going to put a link to that in the show notes.
Oh, I'm very glad, because that was what I was thinking then. How do I know where the endemic areas are? And you've just given me the answer, so that's great. So there's one licensed vaccine that's called Ticovac, and it's available in the UK. And there's a junior version of that same vaccine for children.
I wonder how long the meeting was to come up with that name.
Well, it kind of does exactly what it says on the tin, doesn't it?
Yeah, exactly.
And it contains the new Dorfel virus strain, which is effective against the European strain and probably also against the Far Eastern strains. It's an inactivated vaccine that's cultured on chick fibroblasts. The junior vaccine is used for children aged between 1 and 15 years inclusive, and the adult vaccine is for those aged 16 years and older. Both of them have a 3-dose schedule, though, with the second dose being given between 1 and 3 months after the first dose, and the third dose being given 5 to 12 months after the second dose.
Administration is in the upper arm or anterolateral thigh, and it can be given at the same time as other travel vaccines, but a different limb should be used. Adverse reactions are rare. The usual local reactions following injection may occur, and any suspected serious adverse reaction should be reported through the yellow card scheme. A booster dose is recommended every 3 years after the initial 3-dose course if the individual continues to be at risk. But does the vaccine cover other tick-borne diseases such as Lyme disease, Caroline?
No, unfortunately it doesn't. There isn't currently a vaccine against Lyme disease, but research is ongoing.
So here are your learning points for tick-borne encephalitis vaccination. Consider discussing and offering vaccination to individuals going on walking holidays in high-risk areas.
And vaccination is not currently recommended for walking holidays in the UK.
Okay, so time now for our primary care superheroes.
And we asked you where you were listening and what you're doing, and you didn't let us down. Thanks for all the texts you've sent in so far. So first one this week. Hi, I'm Ola, a GP in Cambridge. Hi, Ola. I am also in Cambridge, so thanks for the message. And 6021 on the text says, love your podcasts. MRC GP in 2002, but now living in Auckland, New Zealand. I often listen in whilst doing my ironing on my day off. It makes the ironing go so much easier. Thank you. Thanks for that. And if you do want your name to appear, make sure you put that in the text message for us.
Exactly. Thank you for those. And 4734 on the text says, doing my morning exercise routine. That's what they're doing when they're listening to the podcast. And our winner this time is Dr. Tammy Downs. We think you're in Whitney, so hello to you. And you've texted in saying, you asked us where we're listening. I'm currently on holiday and on a morning run in sunny beach, Bulgaria. As I paused to send this text, I looked around and I realised that I've accidentally ended up on a nudist beach. An education in anatomy, even for an experienced GP. And so I will send this text and run on quickly. So thank you for that, Tammy. That's brilliant.
Amazing.
Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. So how do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. So here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, Red Whale Pod.
And if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds. We'd really appreciate it. And if you can spare a little more time, then please leave us a nice review. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, and don't keep it a secret, please tell everybody that you know who might also benefit from listening. Now, all the resources that you need are in the show notes and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want us to see something about the podcast, then please use #RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Caroline Green.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Goodbye.
Bye.